Welcome to Focus on Health, a series of educational programs highlighting current health issues sponsored by the Department of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, host of the program and Associate Professor of Nursing at Salisbury University. My guest for this program on Alzheimer's disease is Dr. Alan Anderson. Welcome to the program, Alan.
Thank you.
You are board certified in geriatric psychiatry, and you're also the medical director of the Samuel and Alexia Bratton Memory Clinic located in Easton, Maryland.
That's correct.
And I know you have many, many years of experience in dealing with patients with Alzheimer's disease, so you're the perfect guest to speak on this subject. But I think the first thing we need to address is what is the difference between Alzheimer's disease and what we hear a lot about, dementia.
Yeah, so it's a good question. Dementia itself is an umbrella term. It doesn't refer to what's the cause of the dementia. So when you select a term like Alzheimer's disease, that would refer to a specific type of dementia. There are, of course, other reasons why people become demented as they get older. One of the other common causes is cardiovascular or cerebrovascular disease, which means that there's some compromise to the blood supply to the brain. Typically, these people would have had strokes. Other diseases like Parkinson's disease, there are some medical causes of dementia. There's a condition called Lewy body disease. So Alzheimer's is one type of dementia, with some of those that I've mentioned making up the remainder.
And how common is Alzheimer's disease?
Alzheimer's disease is quite common. There are studies that show that if you live long enough, hopefully many of us will, that by age 85 we may have somewhere between a third to a half of us will have the disease. So maybe up to 50% of people who live to the age of 85 will end up with Alzheimer's disease.
And I know that, some other statistics that are out there is every 69 seconds someone is diagnosed with Alzheimer's disease, and it's the sixth leading cause of death in this country.
Right, and in fact, not only that, but it's a cause of death that we don't have any very effective treatment for or any cure for.
I know, it's the only one in the top 10, I believe, that has that designation.
That's true.
So it is something I think many Americans are worried about, or more so baby boomers, because we're aging and...
Right. Well, as you we've seen our population get older and older. The age group, for instance, over age 85 is expanding very rapidly, and that'll continue to expand as the baby boomers carry their better health habits into older age. Also, medical technology has improved to where people are staying alive during an older stage where they develop the disease. So the incidence of Alzheimer's is going to significantly increase over the next 10 to 20 years.
Now, other than age, you're saying age is the major risk factor, just getting older. What are some other risk factors for developing dementia or Alzheimer's disease?
So there are some other risk factors. Perhaps one that is of concern to many people is family history. So that if you had a family history of someone having this disease, you have an increased risk of getting the disease as you age. Head trauma has been associated with Alzheimer's disease. In fact, there's studies showing that professional football players who have had a lot of head trauma, minor kind of head trauma, perhaps not everybody's on the football field is having a concussion every week, but the head trauma that may cause some brain injury that builds up over time may be a factor. Boxers, for instance, have a high rate of dementia as they age. There are some other factors that contribute. There's a link to illnesses like cerebrovascular disease and heart disease, as well as diabetes, that may predispose or increase the risk of someone developing the disease.
So you're saying age is the major risk factor we think most about. Will everyone get Alzheimer's if they live old enough?
No, in fact, if you look at these studies, at least 50% or more people as they age will not get the disease.
Well, that's good news.
That is good news.
We can hope we're in the other 50%. Now, what about genetics? I do know that there are some early onset cases that are very directly linked to a genetic feature. So.
Right. So a very small percent of Alzheimer's patients, somewhere 1% or less, have this early onset, very strong genetic linkage. The genetic linkage is such that if your parent had that type of dementia, that type of Alzheimer's disease, you would have about a 50% chance of developing the disease. Again, these are rare cases of what they call autosomal dominant inheritance, But outside of that 1% or less, the remainder, the bulk of patients with Alzheimer's disease, have a type of disease that has some links to genetics, but isn't as strong a link as the autosomal dominant early onset pattern.
Now, what early onset, does that mean what, 40s, 50s? Is that considered early onset versus the usual onset in the 60s or 70s?
Essentially, we sort of set the limit at 65. So anything that happened prior to 65 would be considered somewhat early. In these genetic early onset cases, some of them do develop the disease, sometimes in their 30s, but more often in their 40s or 50s.
Now, Alan, we know Alzheimer's disease is definitely a disease now. It's not a normal part of aging like we once thought, senile dementia and such. How does one know what's normal memory loss then? We do know there are some changes with aging that are normal with regards to memory loss. So how do you know the difference between normal memory loss and that associated with dementia or Alzheimer's disease?
A good question. Many people do notice as they get older, typically this might start in the 50s or 60s, that they have some trouble with certain types of memory. They may have trouble remembering names. There's often proper names of either people or places. They may have sort of that tip of the tongue syndrome may come up a little more, where they know what they want to say but have trouble retrieving it, and it may come seconds later. This is not Alzheimer's disease. There is a condition often referred to as age-associated memory impairment. The symptoms are mild. It does not cause an impairment. So one of the ways that we classify someone as having a disease state, and in this case Alzheimer's disease, is to notice that the symptoms cause an impairment. There's a problem in their life, either at work or in social relationships or in some sphere of their life that wasn't there prior to any kind of memory problems. The memory loss of Alzheimer's disease tends to be more profound, more significant, extending more than just names and places, and does cause some impairment in day-to-day activities or a person's life.
So what are the major symptoms of Alzheimer's disease? I guess talk about them early on, when families should get a concern that their loved one may be exhibiting symptoms, and then as they progress.
So the major symptom of Alzheimer's disease typically is centered around short-term memory loss. So long-term memories are if someone came in saying that they had good short-term memory, but long-term memories was lost, that would not be a likely symptom of Alzheimer's disease. That would be rather uncommon. So short-term loss would be things that people forget within minutes or within the last 24 hours. And that tends to be one of the typical early findings of Alzheimer's disease. But it's important to note that just memory loss itself doesn't make a diagnosis of either dementia or specifically of Alzheimer's disease. It's important that there be other connected symptoms. And those typically involve areas of either language dysfunction, such as people not being able to name things properly or have other language disturbance, to then a very common other symptom of Alzheimer's disease is executive dysfunction, which has to do with the way the front of the brain or the frontal lobes are operating.
And what would be some examples of dysfunction in that area?
So the frontal lobes of our brain are often thought of as our control or executive centers. So that's where we make sense of the world. That's where we use our reasoning and judgment, where we can plan and sequence things. It sort of gives us the ability to appreciate nuances in our environment and in our lives. It also tends to be an area where we are able to put our brakes on. So it's an area where even though we may have impulses to do things, the frontal lobe comes in to play and helps us refrain from impulsively doing acts.
Like saying inappropriate things or undressing in public, those kind of things.
So right, when we start seeing some of those behaviors in dementia patients, that would be then a symptom of that part of the brain failing.
Now, can depression be a symptom of early dementia, or is that a separate entity?
Well, actually, that's an interesting question. Depression itself is not considered a core criteria for Alzheimer's disease. It frequently accompanies Alzheimer's disease. In fact, there are some patients that have what we would refer to as a prodrome, or sort of an early symptom complex, where they have depressive symptoms and maybe even a severe depression that may occur years prior to any memory loss or onset of dementia. Now, that doesn't happen with everyone. Certainly there are people that never have depression that then develop dementia and Alzheimer's disease. But there's a subset of Alzheimer's patients that maybe 2 to 5 years before they have their symptoms of memory loss and develop dementia, have a depressive syndrome.
Now, the general course of the disease, I know most of the literature says it can go from 3 to 20 years, with the average being about 8 to 10 years. How do the symptoms progress? Like what eventually occurs with the patient? It's
Right.
not a good story, but I think it's important for you to talk about
No,
it.
it's not a good story. The disease does progress typically through what I think most of us consider to be 3 major stages. A mild stage, then transitioning to a moderate stage, and then transitioning to a severe stage. During the mild stage, symptoms are generally mild. The impairment in one's life is generally fairly minimum. It does not create typically the kind of behavioral problems that you may see in the later stage of the disease, which we can get to in a little bit. And so people's lives aren't impacted as significantly during the mild phase. The middle phase of the disease occurs with more damage to the brain, and therefore more symptoms are likely to come up, particularly as the disease starts to expand much more beyond the memory centers. And there you get more frontal lobe function, more problems with behavioral issues that come up. And that may be a problem that then creates difficulties for families and patients in terms of independent living. Issues like driving and safety come up. Finally, the end stage of the disease, which is very difficult for families to watch, because then people are becoming almost non-communicative at times, where they can hardly use language at all. They may become bedbound. They're more prone to serious medical problems coming up. And many of those patients reaching the final or last stage do end up, for instance, in nursing homes or other institutions.
And they don't typically die from Alzheimer's. They die with Alzheimer's and die from, say, pneumonia or other problems associated with being bedbound.
Right. So if you were to ask what is the immediate cause of death, it's something that's related to a medical complication that possibly wouldn't be there if the person had Alzheimer's disease. So when they're bedbound, they're more likely to develop bed sores or ulcers that can lead to infections that become serious, and they can die from that. Pneumonias are common, and part of that may be the body not remembering how to swallow properly. And so people in the end stage of the disease may aspirate and cause pneumonias more regularly. So yeah, the immediate cause is not, well, it's Alzheimer's that caused them absolutely to die, but it's a complication that's there because of the Alzheimer's disease. So we have made some inroads in having doctors list Alzheimer's as the cause of death, rather than saying the cause of death with pneumonia or infection.
That certainly has been helpful, I think, in really understanding the disease and all the ramifications of it when patients reach that end stage, and most do.
Right.
Now, I guess the important thing is talking about evaluation and how someone is diagnosed, and that's a very important thing that needs to happen, even though we don't have a cure or treatment that really works well. It's important for people that notice these symptoms to have their loved one evaluated, and that's where you play a big role in that, because you now have a clinic in the Easton area based at William Hill Manor, the Gardens, and you do a lot of work in this area. So tell us in detail, what happens when a family member brings someone in with concerns that they may have dementia and they want to get a diagnosis.
Sure. So, and first of all, I think it's important to mention that we're the only clinic that's devoted specifically to evaluating memory disorders in people that may have dementia. But from a numbers standpoint, there's no way we could handle if everybody with a memory problem wanted to show up at our door tomorrow. So it's important to put out there that most primary care physicians, people like family doctors and internists, are well equipped to do some of this screening and evaluation right in their offices. It happens that many more patients that come to us are being referred from internists or family doctors, perhaps because they have behavioral aspects of the disease or because they're not sure of the diagnosis. But essentially, if there's any type of significant memory loss, memory problems, I believe, even though it may seem mild, it's very reasonable to get that checked out. And a simple visit to a primary care physician would be a good start for that.
Well, aren't there some causes of dementia that are reversible, and that's why people need a workup?
Right. So that's an important point. We do see patients, it's not common, probably somewhere less than 5%, that have a discrete medical cause, things like hypothyroidism or not having an adequate supply of thyroid hormone in your body, a common condition as people age, vitamin deficiencies. There's the longstanding finding of B12 deficiency causing perhaps either depression or some dementia findings. There's been some recent focus on vitamin D, and when people have been tested for vitamin D, it's very common for people as they get older to have lower vitamin D levels. There are then some other kinds of metabolic problems that might exist, electrolyte abnormalities, liver disease, kidney disease, other things, diabetes and its effects on the brain. So there may be other reasons other than Alzheimer's disease why people may have memory disturbance. And typically a doctor, whether it be myself as you're coming to the clinic or whether it be a family doctor or internist, is going to do a series of blood tests and probably a study of the picture of the brain, a neuroimaging study, to look at ruling out any kind of neurologic or medical cause that would potentially have a treatment.
Now, you mentioned families will take a person to their general physician for a checkup, and memory loss is sometimes, I should say that's always there. And you mentioned behaviors. What are some of the behaviors that may occur and have a family member say it's time to take them to the doctor to get looked at? Because that can be really telling.
Right, and so you may have people, for instance, overlook some of the memory problems, and then when things progress to get to one of the behavioral manifestations, it may be time to say, well, this has now progressed to something more significant. Probably the most common behavioral problem we see is depression. Now, depression it typically doesn't cause the kind of behavioral problems that might be dangerous or harmful, unless, of course, one is contemplating suicide. That's certainly an emergency situation. But depression can be very debilitating and can affect one's life in a very negative fashion. Depression may come early in the disease because people are sensing that they're losing their abilities, and that can be sort of a trigger for depression to start. And typically depression isn't going to be something that we'll see in the very late stage of the disease, because by that point in time the patient has deteriorated with their mental abilities to really not have much mental activity that would allow depression to be present. So it's more a problem in the early and middle phase. But as you get to the middle phase, particularly when the disease is now moving through the brain and affecting more of the frontal lobe function of the brain, then you tend to see some of these problems with impulsive behaviors. And it can be quite surprising to families. I mean, families may have a family member who has been a very shy and reserved and polite person all their life. Now suddenly they're saying very inappropriate things in public, perhaps sexual comments, perhaps foul language or curse words. And this to families is quite disconcerting.
I know that occurred with my mother. She had the disease, and she has the behaviors are what had us take her to the doctor. It wasn't so much the memory loss; we were kind of in denial about that. And oftentimes, spouses, cover these kind of things up because they're very fearful.
Right. And then sometimes you can see some of the frank aggressive behaviors when there becomes physical aggression. And families, of course, need help when it gets to that stage because there's risk of harm to either a family member or somebody else or the patient themselves.
And often do problems driving, or is that often a factor when they start having difficulty driving or getting lost, those kind of things?
Yeah, and this is, of course, a very controversial topic, a very difficult topic for families and the patient with Alzheimer's to address. Driving is associated with independence, and particularly if you look at rural areas where there's a paucity of good public transportation, to lose one's driving skills, it really is a hit on one's self-esteem and ability to feel independent and a whole person. So it's not to be taken lightly. On the other hand, we certainly have to be aware of public safety concerns and not have people out on the road that because of the progression of disease are impaired drivers and then pose a risk to other individuals and themselves on the roads.
And of course, they can get lost on foot as well, wandering from the home.
It's true.
Safety issues. So a lot of concerns here. So someone comes to your office. And you're saying often it's referred from a general physician, so they might have had all the lab work and such, and an MRI or a CAT scan. So then what will you do once they come to your memory clinic as far as more detailed evaluation?
Sure. So, of course, we're going to really focus in on the dementia symptoms. Important for us is to get a good temporal progression of those symptoms. So really try to tease out, when did they first start? Did they come on gradually, slowly, sort of what we'll call an insidious fashion, which is true for Alzheimer's disease. That's compared to, for instance, dementias that may occur for medical reasons where there's a sudden onset. Someone has a serious stroke and there's a sudden onset of problems, or someone has a sudden change in an electrolyte due to some medical problem. There's a sudden drop in their cognitive abilities or mental functioning. So we want to make sure we tease out that history to be certain that it does fit an Alzheimer's diagnosis. And then we're going to look at, okay, as time went on in the history, what other symptoms appeared in addition to memory problems. Focus on the type of memory that is impaired. And then after we gather that history, also looking at things like family history and other medical history, then we're going to move into the examination of the patient. The examination of the patient will include some basic physical and neurologic exam, but we'll really focus on the tool that psychiatrists and neurologists and others use, a mental status exam. So this is going to focus in on aspects of the person's presentation that link to what their mental content is about. We're going to supplement that face-to-face discussion with some pen and paper tests. So some tests that we will do in the office that will look at short-term memory function, that will look at executive function, that part of the frontal lobe. So we're not just looking at memory, we're looking at other brain functions by doing a handful of tests that will take us in the office about 20 or 30 minutes. And then as we review the history, the results of our mental status exam, some of these memory and other tests, and put together that with the results of lab testing and neuroimaging, be able to come up with a provisional diagnosis of perhaps Alzheimer's disease or some other type of dementia.
So it sounds like the family or significant other is very important here in giving
Right.
you information that you need.
Right, family is very important, and it's rare for patients to come to my office without some family with them. Occasionally that happens, someone's living alone, they've noticed some problems and they will show up. But it's very important that even in those cases, if there were no family, we get some collateral information. So we might want to contact neighbors, close friends or acquaintances. If people are living in senior centers, they may have staff that know what the patient's been going through at those centers. So it's vital in this field to get other history, not just from the patient alone.
So a lot of this is accomplished within one major initial visit with you, and then looking at all the labs and neuroimaging.
Typically, we don't say that we're going to know for sure at the end of that initial visit that this is a diagnosis of Alzheimer's disease or something else. Often we'll leave the patient and family with what we would consider a provisional diagnosis. There are cases that things are a bit more complex and the diagnosis might be given after a second or third visit to collect more information. Because one of the other things is most of these people have some substantial medical records. It's rare that a person over age 65 comes to my office and has no other medical problems. So we also want to review some of the medical history you obtained from other doctors.
Now, are there some cases where there's a mixed type, with Alzheimer's and the vascular from, say, the little mini strokes or things like that?
Yes, in fact, that's a very common presentation. There's a connection between cerebrovascular damage, which is damage to the brain due to some compromise in the blood supply. While in sometimes that's quite evident because the person has had discrete strokes, which would indicate an area of the brain that's now dead, no living brain cells because the blood supply was absolutely cut off. There are cases, and this may occur in people who have things like coronary artery disease or kidney disease or diabetes, where the blood supply is diminished. And so there's a thinking that that's an added risk factor for Alzheimer's patients if they are predisposed to having some sort of compromise to the blood supply to the brain.
Now, I know with families, oftentimes, they're in denial. They see these symptoms, and it's hard, to accept the fact that there could be something going on that could be an Alzheimer's disease diagnosis. But what is the importance of an early diagnosis?
So we believe early diagnosis is very important for a number of reasons. One, it allows for people to begin some planning process. Most of us should have already some of that in place, but studies show that still very few people, let's say at age 60 or 65, really have executed good living wills or some sort of documentation of what they want at the end of life. So early diagnosis allows for that to occur. It allows for better financial planning so that people can start to think about the future and how things are going to go. With the medical kinds of treatments we have available for many chronic disease states, many people with Alzheimer's disease will stay alive and healthy for quite some time. And so it's a good time to start planning for that. So that's one of the main reasons. But the other reason, and probably the second most or equally important reason, is to think about early treatment. Studies have demonstrated that some of the treatments that are available for Alzheimer's disease seem to work better the earlier they're started.
And let's talk about some of those treatments. I know there's various medications on the market.
Right. So first of all, just to start out by making sure people understand that unfortunately we don't have a cure for the disease. So there is no treatment that will arrest the disease, that will reverse the disease in any way. Hopefully with continued research will come up with something in the future that will be more like a cure or a treatment of that type. So the treatments we have, most of us would label as symptomatic, meaning that they will improve the symptoms in some patients. Typical for most treatments in psychiatry, not every patient is going to get a benefit. So even patients with depression may not respond to certain treatments for depression. The hope is, of course, that we can benefit a majority of patients to some degree. The medications that are out there do have science behind them to demonstrate that patients on these improve. Their cognition can improve, their memory can improve. And by doing so, essentially what we may be doing, and studies have clearly shown this, is giving them some added life at a higher functioning level. Now, where, for instance, that could be seen as very important is keeping people out of institutions. And so some of the studies have clearly shown that if you go onto medications early in the course of the disease seems to get somewhat slowed down a bit. So there's an improvement. You're functioning a little better than those who wouldn't be on medication. And for that reason, you may have a delay to where you get to a point that you would need, let's say, nursing home or some institutional care. So that it keeps people at home and with their families and in the community longer.
So what are examples of some of these medications? I know some are used quite a bit.
So right now we have available for treatment two groups of medicines. One is called the acetylcholinesterase inhibitors. That's a mouthful. I don't expect listeners to understand all that. But essentially they get into the brain and they help the disease by improving a concentration or the amount of a certain neurotransmitter. These are chemicals in the brain that are important for normal nerve function. And in Alzheimer's disease, this chemical, the chemical itself is acetylcholine, is reduced. So these are medicines that include Aricept, Exelon, and Razodine. We have an older medicine that's just not prescribed much anymore called Cognex, but the four of them are in that class of medicines. And then there's a second group that came on the market a little later, although it's been out for some time. And the medicine in that group is Namenda. That it works by a completely different mechanism. That works on a different receptor subtype. And by doing so, helps to stabilize the brain and reduce the negative effects of a chemical that kind of destroys brain tissue.
And you're saying some of them can be effective in some people. Is an Namenda more for later stage, or are they all only used in the earlier to mid stage?
And this is where you get to some interesting policy issues, perhaps. And I say that because Namenda, unfortunately, was never able to achieve an FDA approval for early Alzheimer's disease. Even though there is some data to show that it could be of benefit, the data wasn't robust in early disease. So its use is reserved for moderate or severe dementia. The other medications have all been shown effective from mild to moderate, with one exception being Aricept, which also demonstrated data to get an approval for severe disease. So essentially, you can use them throughout the course of the disease. Namenda doesn't have the approval for mild, but many of us and many clinicians in practice will use Namenda even in mild disease to try to offer some hope. I mean, one of the real negatives of this disease is we don't have a very effective treatment like a cure. And there are people in the scientific field that would argue that these medications have modest effects and in many patients minimal effects. And my counter to that, and so why use them? My counter to that is, well, we don't have other solutions here. And the other piece is we never know whether or not the patient sitting in front of us today is going to have a mild effect or a very significant effect. Because when you look at studies, that's a middle effect. That's showing what the average effect is. And some patients in those studies had a tremendous benefit from these medicines.
And there is such variability in how people will decline over time. So I guess you don't know unless you try, type of thing.
Don't know unless you try. And again, it's my belief and most experts that people do deserve a trial on these medications because it's a terrible disease and we want to try to manage things better for them.
Now, how long is a trial? I mean, someone on it for how many weeks or months until you see a benefit or not, or the side effects outweigh the benefits? How do you look at that?
And the answer to that question spans a wide range of opinions in the field. There are some people on the more minimal end who will say that the medicines are effective, but that effect is not long-lived, and perhaps after 6 months, try to people off the medicine. The other side of that argument would be, well, there's data to show that when you stop these medicines, people do decline. In fact, in shorter term studies, people decline to the point that they look the same as if people in the study were never on the medicine. But then the question comes up, well, how long? A year, 2 years, the rest of one's life? And part of that decision right now is not as much data-based. We don't have a lot of data on the long-term benefit of these medicines, and part based on what the function is of the patient is. And so the most aggressive approach would be to say, as long as patients are having some functions that these medicines might help, why would you want to stop them? It's sad when you sometimes stop these medicines and see suddenly that the patient no longer recognizes close family members, or they may lose the ability to use utensils and now have to be fed. Sometimes when you restart the medicines thinking, okay, we lost that, let's get a medicine back on board, sometimes those functions come back and sometimes they don't. So it really has become somewhat of a dilemma in our field to try to make that call, how long do these people stay on medicines, which is also balanced by the fact that for some people these medicines are costly if they don't have a prescription plan. So I wish I had a more concrete answer that could say this is how you do it, but a lot of it is art, working with the family, trying to decipher how much benefit is being obtained by the medicine, what side effects, of course, whether that's an issue, and try to make a balanced decision with family on how long to treat.
And are these medicines mostly used when the patient's at home? Once they require institutionalization or more towards the end stage, we don't keep them on these medicines anymore?
I do. I keep people on medications even when they go into institutions. You sometimes see doctors in the community who will say, well, person's now in a nursing home, why do they need to be on the medicine? My counter argument to that is, well, they're going into a nursing home, fine, but maybe they still recognize family members, maybe they still participate in activities, maybe they still are able to feed themselves or do some things for themselves. And it may be that the medicines help to promote some of those activities. So just because someone goes into an institution, it doesn't mean their life is over. Toss the towel in and not help them anymore. But unfortunately, you sometimes see clinicians who think that way, and like a nursing home is the end of one's life. Well, it's not. I mean, nursing homes have changed, Mary, as you know. They're not these warehouses where, when we got drug off as kids to see our great aunts, we hated to go there because they smelled and they were dark and people were just snoring all the time because they were over-sedated. Nursing homes now are very active communities where people have activities and lives. So it may be important to keep these medicines in place to keep them active in a nursing home setting.
Yes, plenty of activities going on that if people are more alert and able to participate can greatly enhance their quality of life.
Absolutely.
Now, what about family interventions? I know you want to talk a little bit about that because it's a family disease. It impacts the spouse, the caregiver tremendously.
In fact, when you boil down some of the behavioral problems you might see in the middle stage of the disease, a very significant effect of why they are often present is the lack of family appropriate response to the patient. It's easy to understand that. A spouse may have been living with their husband or wife for some 50, 60 years and been used to responding in a certain way with them. Suddenly the patient now has this disease where they respond differently and the spouse can't make a change to responding differently. So the spouse may actually instigate or provoke the patient, not purposely, right, but just by not knowing how to better communicate with the patient. So we at the clinic, for instance, do a lot of work with family members to educate them about how they may change their pattern of communication, their behaviors, so that things stay at a comfortable level and don't escalate into these behavioral problems.
And I know they can also reap a lot of benefits from support groups. Right. They're not for everybody, but for some people it's respite, it's talking to other people that are in the same situation, getting tips on caregiving and such.
Right. We do a lot of education either in the meetings with me or the nursing staff that work with patients when they come in, and then we refer some families to social workers that work in our clinic to do therapy, to counsel the families. But really there are other sources. I think support groups in the community are an excellent idea. And then there are some books, and I want to actually promote one. I don't have any connection to the author, but the Creating Moments of Joy, a book by Jolene Brackey, is just an exceptional book for caregivers to get because it teaches them how to take these very tough situations when emotions boil up and people get at each other because of the problems communicating this disease, and just twist that a little bit so that it becomes a more joyful moment. It's not hard to do, but you need to practice at it, and the book can help you do that.
Well, I know the other book out there is a 36-hour day. That
Right.
was one of the first books that talked about Alzheimer's caregiving. So there's plenty of information out there for caregivers. I know when back in the 80s when this first started becoming more of an issue, you couldn't find any information. Now you can go online and find lots of information and websites and many, many books. So.
And in fact, going back to the first time we kind of met was through the local Alzheimer's Association here in Salisbury. And that's another good resource because they have a library and they provide a lot of help for local people who are looking for solutions to bettering their lives.
And all that's online now. You
Right.
know, you don't really find an office anymore, but you can go online and just get lots of information, anything you could want on any topic related to Alzheimer's care. So that's good news for caregivers. Now let's talk about where we are in research. Since we have such limited treatments, most of which don't really alter the course of the disease, they just help with symptoms for a temporary time. Where are we in research?
So research is another intriguing part of this disease. If you go back 20 years, or let's say during the last 20 years, there were lots of people predicting we'd have a cure in 10 or 20 years. Lots of research went into place looking at different ways of approaching this disease. We have had in the last several years a number of failed trials that looked promising in early small studies, and then you get to doing these larger studies, which are really what science is basing recommendations for treatment on, and the medicine doesn't show a benefit, this experimental medication or treatment. And unfortunately, we've now hit a number of these failed trials, and it's created some concern in the area of research in Alzheimer's disease. One of the prime examples of that was all the hype around this vaccine study. Animal models were developed, vaccines were developed against amyloid plaque, which is part of the problem in Alzheimer's disease. And these mice under these experimental treatments where they got the vaccine just wiped out plaque from their brains. It was just an amazing discovery. As that went to human trials, it not only didn't do what we hoped it would have done, but it actually made people sick. There are new vaccine or new immunotherapy trials where they're using different varieties of immunotherapy techniques to get at things like amyloid protein deposits in the brain. so far, some of them haven't been too encouraging either, and some of the other treatments we've had, treatments that have often focused on this amyloid protein, have shown themselves to not be very beneficial. What we're starting to learn about this disease, a very important point about the research, is that when people get symptoms, this disease has already been present likely for several decades. So at the time you're showing even the earliest signs of memory loss, the brain is riddled with the disease process. And we're beginning to realize that that's likely one of the main reasons why research attempts at treatment have failed. We can't take a brain that's just riddled with disease and suddenly fix it. I mean, if you look at cancer, if you get a cancer at an early stage where it's encapsulated and small, you can eradicate it. But if that has spread throughout the whole body, it is very tough, unless it's very sensitive to chemotherapy, very tough to then cure that cancer. And that's what we see, I think, in Alzheimer's disease, is a process that's going on for decades. We're now getting into the game because of patients coming in with memory disturbance and other cognitive problems, but we're getting in too late to make a significant difference.
And you mentioned the physical changes, they're significant. You have the amyloid plaques, and we talk about tangles, the brain actually shrinks some, and you're saying that can all be there for decades before someone has symptoms. So I know I hear a lot about trying to find a biomarker, something in the bloodstream early on where you can address it sooner.
Right, there's a lot of research going on. Actually, even at our clinic, we've done some clinical trials, and we're doing a clinical trial currently looking at a potential biomarker. So the concept is we develop something that people could have as a test early on, perhaps even as early as in their 40s. It would be able to demonstrate that they're an individual that will likely, as they get to 60 or older, develop Alzheimer's disease. Of course, there's a lot of concern about that too, because we've seen in other conditions like Huntington's disease, where people can be tested, that it can create a lot of undue anxiety. Do people change their lives if they take a test when they're 45 and it shows they're going to have Alzheimer's disease? So there's some ethics involved in how we'll use those biomarkers, but ideally, if we develop a good solid biomarker, one that's sensitive and specific for Alzheimer's disease, we would then have a tool to start researching treatments that could be put into place when the disease is starting, not 20 years later.
And is some of the emphasis using these families that have that early onset gene as
so
a good starting
big
point?
focus of current research is going to be taking these autosomal dominant families where it's 50% chance of getting the disease, because they are a good population to study, because half of them will get the disease.
The other thing I've heard, and I know you've probably mentioned this before, is if we could just delay the onset of the disease, say 5 years, that would make a huge impact.
Right. And to do that, the problem is we've got to change behaviors. I mean, our country is experiencing an epidemic of obesity, type 2 diabetes. Type 2 diabetes is seen as a significant risk factor for dementia and Alzheimer's disease, risk factor for stroke and other. So there is the possibility that if we could get people to live life the right way, eat healthy, exercise physically and mentally, so exercise the body, exercise the brain, there may be some research that comes out over the next several years that really helps give some direction on particular supplements one might take. So particular things like fish oils or certain vitamin supplements and other supplements that like antioxidants. Right now the data is there that it may be helpful, but we may have more data to show that some of these lifestyle changes, exercise, mental exercising, supplements, dietary changes, could really have some impact and make the difference between getting the disease at 70 versus 65, which I think could be a very beneficial thing.
So you're saying those are things concerned baby boomers or family members that have it in their family can do to maybe prevent or delay onset is a good diet, heart-healthy diet. We've been saying that for years anyway.
What's good for the heart is good for the brain. The problem, of course, is there's not the data for me to sit here today and say, if you do these things, you'll avoid Alzheimer's disease. I mean, the fact is that age and family history are still two potent risk factors. But again, perhaps if you do all the right things, you'll get it at a later time. So you will perhaps delay the onset of the disease, and I think that's important for all of us baby boomers to consider.
Right, and you're saying antioxidants.
Yeah, and
Blueberries, I'm big on blueberries.
Yeah,
things like that.
So again, I would say if you're going to do this right, you'd be better off doing it dietary than spending your money on a lot of expensive supplements. And so the heart healthy diet, a lot of fresh fruits and vegetables, concentrating on berries and green leafy vegetables, and also, they teach kids the yellows of the stoplight, yellow, green, and red. So really varying your vegetables and eating, the feds recommend 5 to 10 servings of vegetables or fruits a day. I can tell you, we could survey 100 people anywhere in this country and find probably less than 10% of people eat 5 to 10 fruits and vegetables a day. So it really is going to take a great shift in thinking about how we do things.
Well, a heart-healthy diet has many advantages as well in preventing other disease, but you also mentioned something about exercise. We know physical exercise is important, and what about, you mentioned brain exercise?
Yeah, so let me cover physical first. It amazes me when I go into our facility. We have a wellness center with weight machines or resistance machines, and you'll see these 80, 85, even older people on these machines pushing weights or pushing resistance. So even exercise of that sort, which doesn't take a lot of time. You don't have to go out and train for a marathon here. But either a combination of aerobic and anaerobic exercises has shown to increase blood flow to the brain and be helpful in that basis. But let's turn to mental exercise, because this is a bit of a controversial issue, I think, because, for instance, you have a lot of companies that are racing to get at the baby boomers' dollar by saying, we have these computerized products that will stimulate the brain and will help you stave off Alzheimer's disease. I will say that from my review of this, there's really limited knowledge that that's what you should be doing. I mean, if you have the money, you want to buy some of these fancy things and play with them, that's fine. But most of us believe there are some simpler things one can do that stimulate the brain. And they might include things like taking up ballroom dancing, learning how to play a new musical instrument, learning a new language, maybe going back and taking some community kind of classes at universities often offer adult classes, and learning something new and challenging your brain to work in some way of incorporating new information, new knowledge. And it's fascinating that some studies have shown that mind-body connection might be more potent than just a mental exercise itself. Why things like ballroom dancing, ping pong. They did studies on people playing ping pong, and the brain just lights up. Because if you think about it, ping pong involves coordinated movements of body, but both your body and space and your hand and eye coordination, as well as a mental process of trying to decipher where you're going to place the shot, trying to figure out where the shot's coming. So they had 2 studies that showed ping pong invigorates the brain, and suddenly ping pong clubs in New York City went haywire,
right.
With people signing
keeping track of the score. Right. That's always challenging to me, but yeah, that sounds great.
So there may be many things that are less expensive than investing in these high-tech products, which, I don't know as much about, but certainly anything that stimulates the brain is good.
And a lot of these involve a social component too. Isn't staying active socially also been shown to be helpful? Staying
active socially is important. Again, you look at something like ballroom dancing, where we do a group of people, or some other activities like exercising in a Y, where you're around a social context of people, could be very helpful.
Well, let's wrap up and emphasize a few points. First off, there's a lot of information out there, the Alzheimer's Association website and some others, and we'll post those websites at the end of the program. And then we'll also post information if people want to call regarding research trials or evaluation at your clinic located in Easton. So we'll post that slide for people to get more information. And I think, again, just reemphasize the importance of getting a thorough evaluation earlier in the disease versus later.
Yes, a thorough evaluation is quite important. We have treatments. There are treatments that work. We also want to have time for a planning process in place. And some people may want to also engage in some research trials. So earlier we identify the disease, the better. We also hope at some point we'll find a cure for this disease, Mary.
And I think the planning's important for anybody really, but especially when you're facing this diagnosis for down the road. Maybe appointing a healthcare agent's very important for them to speak for you as to what treatments you'd want or wouldn't want when you get to the later stages. Well, Alan, thanks again for being on the program. Just some wonderful information about this disease that we'll post some websites at the end of the program where people can get even more information about it.
Sounds great. Thank you for letting me be here to help educate people about this disease, Mary.
And thank you for joining us for this edition of Focus on Health here on PAC 14.
Focus on Health is sponsored by Peninsula Regional Medical Center, a proud supporter of PAC 14 programming.